Okay, so as we were discussing, here are our points of discussion. And as we go through here, if you have any questions, unmute yourself. That way I can know. Awesome. Miss James, she says she just does a basic sub 10-minute mile. Love it. I was one of those weird people that I loved to run in high school and even before and then after. Now I'm retired. I don't really run anymore, but I help runners just because I can relate to their struggles and all the things. Chris, a 7-minute mile, whenever I ran a lot. Love it. Yeah, once you start like running and you get efficient with everything, you can get down there pretty good. All right, so let's just review some common anatomy and physiology things. We've discussed a little bit about different joints throughout the body, you know, but let's just get familiar with the foot, because some of us might not have had anatomy at all. In the foot, just like with the hand, you have a bunch of little bitty bones, and you have the carpals and the tarsals in the foot, okay? And then you have the navicular, cuboid, talus, and then the calcaneus there on the back end, and then it leads into some phalanges and dips, ips, pips, if you've ever heard of those. And basically what you need to know for this PowerPoint and for this slide before you dive into your human anatomy class is that the foot is powerful. There's a lot going on there. There is a lot of ligaments, as you see here. You see all those little bad boys? Which is why whenever you injure your feet, it is very, very hard to rehab because we're on them. Hello, gravity, right? We're on them, we use them. Booting is great, but there is too much of a good thing. So, you know, you got to get somebody out of that boot as much as you can and keep things moving. And just because you're isolating or resting one ligament or one bone or one structure, we still have to keep the other structures moving in a safe way. So again, it's a fun one to rehab in the sense that it's challenging for the clinician, but it's very, very frustrating for the athlete, especially if they're a runner, because, hey, they're used to being on their feet. They're used to going. They're used to constantly, especially with runners, you'll find that they're just a breed of their own, okay? So as we kind of go through these injuries and common things, just keep that in mind. The cuboid right over here is a fun one that sometimes if I have a patient with lateral ankle pain, I can do what's called a cuboid whip on that guy and they'll walk out pain-free. So sometimes it doesn't even have to be something like a ligament or muscle. It could just be a bone that's kind of malpositioned, okay? A little bit about pronating and supinating. Does anybody know? Well, we just went over the terms, right? Pronation and supination. Pronation, can somebody unmute themselves and tell me what pronation is? Maybe, maybe not.
Face up. Sorry.
Pronation is
like
that. So hold on, like that.
Yeah, so you're pouring out your cup of coffee or a cup of soup, right? So for the foot, because it's not like the hand, for the foot, it's actually like you have your foot like this and you're pouring out a cup of soup that way. Versus supination, you're going laterally. So you're going on the outside. We'll talk more about that here in a second. And then you have neutral. Now, naturally, pronating and supinating happens every single time you take a step. A lot of people, they're like, oh, well, I need to put wedges and inserts and all these different things to prevent myself from pronating or whatever the case might be. But we also have to keep in mind that we pronate for a reason. You pronate for a purpose. You supinate for a purpose. And it's all a part of the gait cycle, which you guys will, of course, learn in your other classes. And we could nerd out about that a lot. But if you want a little taste of it, maybe go check out Immaculate Dissection. They have some great stuff on that as well. Which, by the way, next time that we dive into muscles, I'm actually going to bring out my Immaculate Dissection pictures, because I found what I was looking for the other day about the aponeurosis and the six-pack abs, and kind of so that you guys could see the drawings, because it's really, really cool to see and kind of get that in your mind. Okay? getting back to what we were talking about, pronator, supinator, neutral. So a lot of people, you know, pronation, you've heard of overpronation, excessive inward rotation of the foot and ankle. So that means that your foot was like this with an arch, and suddenly your arch disappears and you kind of tilt in. Like I say, you do that naturally. There is too much of a good thing where you pronate too much and you kind of have that collapsed arch, so you need a little bit of support. But I always make sure that I educate my cross-country runners, my marathon runners, whatever the case might be, that yes, you do pronate for a reason, and we're going to give you that support, but we're also going to need to actually build up some of the structures within your foot, the muscles, just to give you that support whenever you don't have your shoes on. Because you pronate for a purpose and you do it all the time, we just need to make sure that you're doing the right amount. Common injuries that you see with pronators, so the ones that, again, drop down, it's going to be those medial stress fractures. So that's on the inside, if everybody can see my cursor, right here, kind of up into here. Then you, of course, you have post-tib dysfunction. Guess why? Because it's being stretched, compressed, all these different things. Plantar fasciitis, because guess what? You did have that nice pretty arch, now you don't. Goes to show that you might have some plantar issues. Achilles tendonitis, just because of that inward rotation. So now instead of that Achilles tendon running vertically or straight up and down as much as it can, it has a little bit of a tilt and a little bit of a strain to it. You'll also see medial knee pain and then IT band syndrome, because what starts in the feet usually makes its way up. And I've seen people with, we work on their foot stability, their foot positioning, their shoes, whatever the case might be, and it helps with low back pain. So, I mean, it goes all the way up and down. Supinate. So a supinator, they have that excess outward rotation. And the interesting thing is, like, you can see it in their shoes. And the same thing with a pronator, but especially with a supinator, because do this sometimes, look at your shoes. I do this all the time just to see like how I'm walking. I flip it over and you can see what's worn, what's not. Also, you can like take your hand inside your shoe, which might be dangerous for some of you, but try to do that and see what's worn out, what's not, because that will tell you a lot about what places you're wearing on your shoe and where the bulk of your weight is going, because that matters. You'll see a lot of ankle sprains with this one, just because guess what? They're already on the outside, so it's a nice little trip to go over. But with this ankle sprain also comes with ankle laxity, just because they have them so much. And I'm a big believer in, if you do have multiple ankle sprains as a soccer player, et cetera, you need to go see somebody like myself or a great physical therapist, athletic trainer, because that will come back to bite you later on in your career. Lateral structure fractures, just because guess what? Like the medial, you're on the outside, so you're pulling on that lateral aspect. You have peroneal tendonitis, and as you dive more into your anatomy, you'll see where the peroneal tendons lie, but that's more of the outside of your lower leg. And those guys can get pretty pissed off as well. And then you also have IT band syndrome at the knee, more so than the hip, because of how you're rolling out, and that knee sometimes gets a little bit wonky. Instead of kind of falling in line, I should say, with the toes and kind of traveling forward, we start to kind of bow out a little bit, and it can pull on that tendinous attachment. Now, for a second, I want to pause and say neutral, because there's not a slide for that, because usually it's not a problem. If you are a neutral-footed runner, you don't really have issues. But let me tell you, nobody is really going to be neutral. It's kind of like normal. Whenever you say that this is the normal standard deviation or this is the normal range of motion, there's always quotes around it, because normal is all relative, right? So just as something will be different where your hips are positioned, same goes with your feet. You might have different pronation, supination habits in different cadences, in different strides, in different walking versus running. It all matters, okay? So, what we always love to talk about, feet, right? Everybody loves feet. Whenever you're dealing with runners, you will come across some funky feet, just saying. Like, just, it's kind of like football players, whenever you see their feet and you're like, oh, dude, you need pedicure. They're pretty gross. And usually you have a couple toenails falling off, especially with the marathon runners that I've worked with. It's really hilarious. I love them to death, but they're either a couple black or they've had several fall off. That tells me that something is not optimal, that we need to optimize, but it's amazing what they will go through. And then also stuff like athlete's foot and all the grossness, you know, they just, it's a grand old time. Shoes are a biggie. And really this is for anyone, but especially if you're running. So you have running shoes, you need to make sure that you track, you know, how many miles average you've done in a pair of shoes, but then also consider what surface you're on. Are you on asphalt and concrete, or are you on track and grass? And then I actually left these shoes on here because it always cracked me up. My prior professor did not really run. And I was like, these are not really good running shoes. So I just left them up there because I was like, these are the ones not to pick, okay, guys? These are what not to wear running. But whenever you go in and you are considering a running shoe, make sure that you ask people, because you don't want to grab a bad pair for your foot. And I actually run in Xero shoes, and I love them. And I work out in them as well. And I have had no issues. And I used to have, you know, all sorts of feet issues and injuries, and I haven't had any issues now. So it goes to show you just got to find what works best for you. Whenever you are picking out yours, just in case, even if you're not running, this is just FYI for anyone, make sure that you can wiggle your toes. I like wide toe boxes for my patients because I don't have to worry about black toenails. And I don't have to worry about the piano toes where they kind of start to curl under. You'll see that in soccer players a lot because of our soccer cleats. They kind of crimp our toes under. So I want to make sure that they can have a lot of foot splay. Socks that fit. Men's shoes versus women's shoes, because traditionally there is a little bit of a difference. But I actually have found a pair of men's shoes that I just got smaller that I loved. So again, it's personal to you. You just got to find out what works best for you and get a consult from somebody who knows what they're doing. Pronators, so rigid shoe that's good for rear foot contact, just because whenever you pronate, you're gonna hit that heel a lot more. And so you wanna make sure that there's something there. You also want to pay attention to your cadence, because if you are hitting your heel a lot, it's going to hurt, more tension, more just problems up the chain. But then also it means that your cadence and your gait is not optimal. We need to kind of bring in that gait a little bit, not make it as wide. And then supinators, softer shoe with greater flexibility. I almost say that this is bullcrap, just because supinators, they're already that high arch. And so sometimes if they have too much of a good thing, too much flexibility, it can actually make their plantar fascia really, really angry. So it just depends on the person. And you need to have somebody look at your feet, take a gander at your gait, and then you can go from there. Because your supinating and your pronating will change as you go through those cycles, okay? Whenever we're looking at shoe anatomy, because yes, there is shoe anatomy, you want to make sure that if you do have a pretty good heel on that sucker, just make sure that it's stable. Don't get one of the ones that have like a bunch of different knobs and they say that it's for shock absorption and all this stuff. I've just seen that go haywire too fast. And then also be sure that whenever you're getting up into the top of the shoe, you want to make sure that it's not digging into the Achilles, and that is as supportive for your foot to not do this. I don't know if you guys can see me, but not slip side to side. Also, it's kind of like with soccer shoes. I'm actually doing a consult with a soccer player right now where she is getting pain on the inside of her ankle, like just at the top of her foot, kind of where the lower limb meets the foot. and it's from her soccer cleat, like whenever she stops, it jams into there and it's just basically bruising that tendon in that space. So make sure that this guy right here doesn't jam into you too much and that you are tightening your shoes appropriately. So with this guy, whenever you have that slip last in there, you want to make sure that it goes the entire length of the shoe, just because you want that support consistent. And you've seen some of them that have like a beefier on the end, like where the heel, because it wants to be shock absorption, but just make sure that it's singular throughout. You don't want a bunch of different layers going on, okay? Again, this is just one of those things where you check out your shoe. The board lasted, so like the tension underneath that slip, and you can feel it usually with your fingers, make sure that it runs the entire length of the shoe, just because, yeah, if they want to boast that they have a bunch of cush right there, make sure that you do have a board all the way across. Few last things. Shoes, words are hard. Shoe last shape. So you have curved, semi-curved, and straight last. What this basically means is that toe box. Do you see the difference? Let me move this over. Everybody see the difference right there? Kind of like what happens at the shoe and the edge. Sorry, I'm having to move this for y'all. Do you see that? See the differences and how it's shaped and at the toe? I am a fan of the wide toe box. So as wide as you can get it, great. I don't really like the straight. The curved is okay. That's just what I've seen in my clients and my patients. But again, it's custom made to you. So you just kind of experiment on your own. Couple more things. So do you have a continuous or do you have kind of that blocky sort of design? Kind of goes back to what I was saying with, is it flat all the way around, or do you have gels? Do you have spirals right here? Do you have those posts? Take that into consideration whenever you're choosing your shoe. Make sure that everything's functioning properly before you hit the pavement. All righty, so with the supinator, we talked about they have that higher arch. These are some suggestions, like general guidelines, but even with these, I have to say, these rules do not apply to everyone. That's just my personal opinion, but this is one of the things that is kind of general information that you will get from a lot of places that you go and get your shoes. I uploaded these slides onto the Blackboard just in case you guys want to take a look. But like I said, whenever you're looking at your shoe, make sure that it fits best for you. You are not cookie cutter. So let's get down to the fun stuff. Common injuries. Plantar fasciitis. Has anybody ever had this? It sucks butt. You have. You're like, yeah, I couldn't walk in the morning and it felt like I had a knife in my mouth. Yeah, there it is. Yeah, it sucks. It's one of those things where you wake up in the morning and you try to take a step and you like hit your butt back on the bed. You're like, oh no. So basically this can come up, it's chronic because of the inflammation status, but truthfully, I've had a lot of people that are like, yeah, it just, one morning I woke up and bam, there it was. Yeah, sure, it was a chronic in the fact that there was a buildup to this and it was probably a little bit of unoptimal positioning or something that was going on for quite some time, but usually it'll come on and you're like, holy crap, there it is. And then it will go away. That's, again, the chronic part. Inflammation of that plantar fascia at the bottom of the foot. This could be to excessive pronation, remember the flattening out of the feet, excessive mileage. So maybe somebody went from 20 miles to 50 miles, just, you know, for funsies. Poor arch support. That's another one, just because you need to make sure that everything that you're doing matches your foot specific. And then also, I have to say, just because this only touches on this, I'm going to add on to this. You have poor calf muscular flexibility. Yeah, but you have a weak butt. I can almost like pinpoint your butt's weak. and your transverse abdominis are probably not optimal, and I could almost guarantee that you have tight adductors. So there's a lot more going on than my plantar fascia hurts. That's just usually what shows up. That's the manifestation of some of the concerns, okay? So it's always a fun, not fun, let's just be honest. It's a frustrating injury to treat just because it takes a long time, because you probably had a lot of time to get there. So it takes a while. Rest, I hate that word. You're not going to rest completely. You're going to be doing things, okay? Do not sit on your couch and eat bonbons and expect you to get better. It won't. It'll just piss you off every time that you walk to your fridge, okay? You're going to want to take a look at your shoes. See if you need some arch support. See if you need some support. See if you need some exercises. You can do something like NSAIDs if you'd like, making sure that you're stretching appropriately. And then you're using something like a roller or something on your foot to start stimulating that tissue. But in addition to this, I would have people do some glute work. See what their piriformis is doing a bunch of other things that will actually get them back on the pavement faster and won't have this come back, okay? Because if you just be like, okay, I'm gonna take 3 weeks off of running, I'm not gonna do anything, I'm gonna let it rest completely. First of all, you're gonna lose all your gains, if you wanna call it that. All of your endurance is gonna be kaput. You're gonna be pissed off because you're not doing anything. And then also, really, it's just gonna come back. It's not gonna be one of those things that just magically disappears. You need to make sure that you are getting after it. I'm speaking from experience. I had this a long time ago, and I was the pissed off runner that was on the sidelines, and I had to learn. So just if you have a patient with this or a athlete, make sure that they're seen, and you figure out what's actually going on, okay? Any other questions before we move on? A couple other ones that we see. Heel bone spurs. These are not fun. Significant flat feet, pronation. You'll see this. It's a result of that plantar fasciitis that did not really get treated. And it's where there's constant stress placed on that attachment to where your body is like, okay, you are pulling on me so much. This is so aggravated and pissed off. We need to give you a little bit of extra buffer. And so the body, in all its wisdom, it decides to build you some more bone. Not exactly optimal on your heel, right? Like that has to come in contact with the ground a bazillion times a day. But basically your body is just trying to give you a little bit more support because it's getting tugged on so much. It's like, okay, we need to beef this area up. It's very frustrating. And some people, especially if they get a large enough one, they might have to go in for surgery. Some people, the body is able to reoptimize and reabsorb. It depends on the person. Treatment, it's not exactly glamorous, but you might need that surgical removal. You can try heel cups, orthotic. You're going to be doing a lot of the stuff for plantar fasciitis because guess what? That's what started it. And then you can have some taping done. I like K-tape for this for my patients. I've done some cupping. That's always an adventure because you never know if you're going to get kicked. I am certified for STEM, words are hard today, for like Graston type techniques where you're using a metal tool and you're doing some scraping on the sole of the foot and then through the calf. Again, you got to watch out for the other foot that's coming at your face, but it is very effective just to stimulate that healing response. But again, it's just a frustrating one because again, it's coming off of that plantar. IT band syndrome. Has anybody had this one? Because this one sucks too. Whenever you have IT band syndrome, I'm thinking of somebody that I actually ran with. She got a scholarship to RSU. All of us did. And poor girl, she got there and she just couldn't shake it. And she even took off like a whole season, I think. And it kind of played back to the whole thing of we weren't strengthening optimally. There was too much load going on that IT band. It never got a tension rest. There was nothing supporting there. And it just never got a break. So it developed into this syndrome of sorts. I use air quotes because everything with syndrome is, that's a rant for another time. But basically it's where the IT band gets so irritated, so pissed off that you have a stabbing pain all the time. And it's really frustrating. You can have it at the hip. So up here, I don't know if you can see my cursor, but right here, you can actually have it down here at the knee. And then some people, they even have down to the foot because some of that connective tissue goes all the way down. Sometimes it's both. Sometimes it's like the whole shebang and that poor person is miserable. But sometimes it'll be excessive pronation because think about how it's tugging that knee inward. So it puts that lateral hip on stretch, excuse me. And then sometimes it is excessive supination, which means that your knee's going outward too, because your foot's going out. And then it's more stretch on that lateral knee, maybe into the hip. And then you get into tight, weak hip abductors. So remember the abductors take your leg away, correct? And then excessively internally rotated hip. I'm going to tell you the treatments here, and then I'm going to tell you some of the things that I've had success with. You can address that supination, pronation, do your RICE, do your NSAIDs. You can try stretching the tensor fasciae latae, which is up here. It's that front pocket muscle. You could try to do like biking and stuff like that to kind of strengthen muscles and just, again, give your body a break. But here's what I've had success with. If you look at the stuff that it causes or that is caused by the weak hip abductors, guess what? We're going to start strengthening your hips, the glutes. We got to get those firing appropriately because if your heel is striking and those are not engaged appropriately, that's going to hurt. We're going to make sure that your hamstrings are appropriately strengthened because if you cannot pull your heel towards your butt, again, it's going to be forcing into that IT band and more. We're going to be making sure that you have the flexibility along with the strength in your adductors. You'll be noticing a theme here of strength. And then also I'll be looking at pelvic floor and lower abdominals because 9 times out of 10, those are shot too. Excessively internally rotated hip, that's because your external rotators are probably not optimal as well. So we'll be looking at those. If you start doing stuff like that, you can see a big change. You can do stuff like cupping. You can do so much other stuff to kind of help that along as well as far as calming the inflammation and stimulate healing. But there's a lot that can be done, but this is a very frustrating injury. Any questions?
Whenever, say, you pop your hip out of place, what is actually being done that you can feel like the popping? Like what actually is that?
Great question. So a lot of times when we feel popping at the hips, it might not be your hip popping out of place. In fact, 9 times out of 10, that's not it. It's actually the muscles or tendons, ligaments slipping over the bony prominence. So something like an IT band or maybe an adductor or your psoas in the front is actually catching on some sort of structure like a bone and you hit that pop. Like I can make my hips pop. I have bilateral hip labrum tears, but then I also have had history of, just hip issues. And guess what? It was from lack of strength, from running too much. So I'm kind of passionate about that. It happens constantly. So you kind of get that irritation there, which might cause pain. Otherwise, it doesn't hurt at all because it's just popping over something. Does that answer your question? Yeah, hopefully it does. But basically it's just that snapping. It's usually like an annoying snap too. And if it doesn't hurt.
My boyfriend, he got in a motorcycle accident like when he was like 10 and like his hips were injured. And ever since then he can pop both of them like in and out. and I just want something to tell.
Yeah, and that might be structural, it might be hip labrum. Because sometimes those will kind of catch, and depending on if it hurts or not, where it's located, is it in the front, is it in the back, is it on the side, that would kind of help us narrow down what's going on. But yeah, and sometimes if you have something like a cardiac or an injury, that'll stick around. And it's just one of those where you strengthen the surrounding musculature to make sure that you protect the space. But, yeah.
So doing like exercises that strengthen that muscle will help it like not do that as much.
Depends on what's hurt. And since I don't know like where the pain is, stuff like that, or the popping is coming from, it's kind of hard to say. But usually if you strengthen, like say around where it's hurting or around where the popping is occurring, you make sure that you have enough mobility within that joint, that usually helps. So just try to get them moving, because that's the best thing, is just to keep that structure moving.
Okay. Thank you.
Mm-hmm. But like I said, I can't really say because I don't know. I haven't seen him. All right, so patellofemoral syndrome. Has anybody ever had this? It's also called runner's knee, jumper's knee sometimes. It sucks. All injuries suck, if you can tell. Basically, this one's interesting. I've had this one too. I've probably had most of these injuries. But it's malalignment and tracking of that patella. This can be due to excessive supination, VMO weakness, which is a whole nother rant that I could go into, because only so many of the population actually have like a VMO muscle. Maybe lateral quad tightness. So it could be adductor medial quad weakness or lateral quad tightness, or excessive Q angle, which we'll dive into a little bit more when we do lower extremity. But basically that's where you're a little bit too knock-kneed, or your knees roll in a little bit too much, okay? Whenever you have this go on, I'm gonna show you this next slide here. You'll have a lot of pain basically here, but a lot of times we'll have it right here and right here. Some people will have it up here, but the main point is because this knee is rolling in, these tissues are getting pulled. And so you have this lateral tightness pulling this patella one way, and you're getting spacing over here. A lot of people with this patellofemoral syndrome, they might have adductors that are tight weak. So they're very weak and they're not giving the support that they need, but they're also very tight. So it's kind of a twofer. And it's a very frustrating one because it can get kind of chronic pretty fast. But as long as you're strengthening the right muscles, and again, I go back to the hips because that's where it starts, and looking at ankle mobility, hip work, and then lower abdominal pelvic floor connection, and you can usually get this situated. Now, sometimes you have somebody who is structurally not sound. Maybe they are built with an excessive Q angle, so you're just going to mitigate as much as you can. I had a patient who had, and the disease just left me, and I can't believe it did, but her knees excessively rolled in. And basically from the ground up to her head was arthritis, different diseases, different things going on. And we were working on her knees. It was one of those where I can't fix the disease that she had going on. We were just trying to strengthen everything around it enough to give it a chance to rest and have the support that it needs. And you might hear my son, he's outside the door yelling at me. But any question on that one? This, again, it's not fun, but it usually comes down to weakness or maybe a structural issue. Alrighty, shin splints. These are not fun too. This is not just for runners. This is for basketball players. This is for soccer players. This is for, you know, track and field. This is for whatever you might have. It's basically, it's one of those that a lot of people, if they have pain in the lower limb, like down past the knee, they're like, I have shin splits. Like it's like labeled shin splits. So that's one thing that you have to watch out for. Your patient or maybe a player will come up to you if you're a coach or something like that. They're like, yeah, I have shin splints. And I usually have to be like, okay, where do you have shin splints? Because it might be on the back side, and we're talking about this is not shin splints anymore. So you have to always make sure that you ask. I've had a couple athletes like that. They were high schoolers. They're like, oh, it's just shin splints. And it turned out to be like compartment syndrome. And we were dealing with something so much worse than shin splints, but they were just pushing through because it was just shin splints. So again, ask. So we call it, usually we call it medial tibial stress syndrome. Basically, it means that you pissed off the muscles that are connected to your tibia, and they're mad. And they kind of get little bitty, like, I don't want to say shards pulling away from the bone, but yeah, that's what's going on. But the shin splints could, be tossed in, and they could have a high ankle sprain, which is a syndesmotic ankle sprain. They could have a compartment syndrome, which is just inflammation of all that fascia and tissue. And that's one injury that I've never had that I never want, knock on wood. Anterior tibialis tendonitis. So that's another one that it's kind of related to. And then again, posterior tibialis deficiency, where they're not having enough strength and it's just going haywire. But again, you have to be able to ask them, where's the pain? What happens, like, whenever you rest it? You have to be able to ask them, what type of pain is it? And does it get better whenever you're sitting down, or does it get worse? And that'll help you a lot in deciding whether or not you need to either refer or if you have a big issue on your hands. This isn't really an injury, but it is an injury. Heat and illness. We've talked about this, where you have the different levels, remember, in our heat illness PowerPoint and discussion. Basically, runners will push through a lot, because I'm not saying that we're stubborn, but we are kind of stubborn. And if they're not hydrating adequately, and they're running in the summer, and they're training for a marathon, it does happen. And then they start to get cramps, and then they wonder why they feel like poop, and they wonder why their training's gone down, and all that stuff. So just something to look out for if you're a coach or something like that. Preventing, don't be stupid, know your own limits. Don't go out in like 100-degree weather. That's always my favorite thing, to see people in my neighborhood that I lived in this house, and I'd see some people around town that were running, and it was like 102 degrees outside. Humidity was crazy. And they looked like they were dying, because probably their body was like, what the fruitcake are you doing to me? But it was just one of those things where I don't want to say you're being stupid, but you're kind of being stupid. Be smart about whenever you run, especially if you're not acclimated to the heat. Make sure that you have the appropriate clothing. Make sure that because a lot of people, they want to lose weight, so they put on hoodies. I understand that you want to lose weight, but make sure that you can still sweat. Make sure that you can still breathe. Make sure that you're taking care of yourself. And proper hydration. Key points to note. Common injuries. So going on, we've gone all through these in our heat illness discussion, but making sure that you know these signs. Making sure that you know whenever somebody's like, they've had too much of a good thing. What the fruitcake? I'm stealing that one. I don't even know where I got that, guys. Like, what the fruitcake, just kind of, yeah. I try to not use bad words, especially around my son. So I've come up with a bunch of different fun uses of words. So if you ever need one, I probably have a few. All right. Remember, when in doubt, ask somebody, because you want to make sure that you're able to get them cooled down and that you don't have heat syncope on your hands or anything like that. Naturally, you're going to have, which these are kind of ugly, they can get kind of pretty, but naturally you're going to have where you find a curb, or you find that you tripped on something. That was my first real big injury, which I, to this day, am so pissed off about. I actually tripped over a blob of cement in the road, and that led to my first surgery. Like, I am not kidding. It was a 5 a.m. run. I think we were going like 8 miles, and I tripped, and my knee like ballooned up, And it was a bad day, and I'm still pissed off about it. So, it's just one of those things, you will run into these issues. So never forget, a strain is an injury to a muscle. A sprain is an injury to a ligament. It took me a while to get those straight. So if you are one of those people that just needs to say that 40 bazillion times, do it, because it's always a good thing to know the difference. Depending on what the issue is, might need to be a few days of rest, might need to be some more exercises, you might need to get some grass in, cupping, whatever the case might be. But depending on how fast you're wanting to get back to your sport or your running or activity, depends on how aggressive you get with it. Of course you have rice, but rice is kind of going away, which reminds me, and I'm sorry I'm having kind of feel like a squirrel moment here, but I have a link to the End of an Ice Age. It's going to be a course that a great athletic trainer is going to be putting on, and it's about an approach to why or why not we should be using ice and heat and stuff like that. If you guys are interested, shoot me an email and I'll get that to you. He also has a free course that kind of comes with it, which is like the front end of it. So at least you could get a taste of it. I took a look at it. He did a great job. And so if you kind of liked our discussion the other day, maybe that's something for you. But the old school rice, you need to heat it, maybe stretch it, but not too much. Okay, again, not too much stretching, so you could just piss it off even more. If you need some NSAIDs for a little bit, go for it, but don't rely on them just to nurse through to your marathon or something like that. Try to get it taken care of so you don't damage any guts or organs. Also making sure that you do stuff like mobility. If you're a foam roller, do some foam rolling. If you like to do any sort of soft tissue work on yourself, do that. Just keeping those tissues healthy and thriving, that's a key. And lastly, overtraining, because truthfully, especially with runners, you'll see this so much. And I went through this, and I can say that it's a beast, because it racks your hormones and it does so much to your body. Chronic fatigue. So if you have a runner or a student coming to you, or say you're working with a marathon runner, and you can just tell that they look like they have not slept in a couple days, or they kind of look like they have a newborn, right? You've seen the tired mom that has the bags. That might be your athlete. If they have excess swelling and they're not injured, but they're starting to notice swelling in their knees, even in their hands, stuff like that. Make sure that you take note. Pain. And I'm not talking about okay, I sprained my ankle, I have pain there. I'm talking about they start saying, okay, my knee hurts, my shoulder hurts, my hip hurts, my back hurts, my head hurts. It's starting to spread. That's a good idea to hey, let me see your mileage. Let's take a look at your training logs. Let's look at how are you performing? What's your nutrition like? What's your rest like? Let's take a look. And then pain that does not respond to rest, stretching, ice, and medications, that's a really big red flag, because their rest, and I'm putting quotations around that, might not be rest. It might be doing something else that is comparable to running, and they just call rest. So again, taking a good look at that. Are there any questions? Because that is the whole PowerPoint, that is the whole discussion. But there's a lot to unpack there, and then I could go even more in depth on things if you would like to. Is there any questions that you've seen or that you've experienced or that just are floating around?
Are you going to be recording this to send to YouTube?
Yes.
Great, because I joined late. Thank you.
Okay, no problem.
I have a
Going back-
question. Oh, sorry. You can go ahead.